My article title is Arch Bar versus Titanium Mini Plate Fixation in Anterior Segmental Osteotomy Orthognathic Surgery. It's an cohort clinical study. In general, various jaw deformities require various osteotomy to solve the functional and aesthetic discrepancy. Furthermore, understanding patient problem, correct investigation, and initial diagnosis are crucial parameters to perform good treatment plan. Essential therapeutic aims of orthognathic surgery are to restore suitable function and normal aesthetic appearance with good stability of the segmented part and minimizing treatment plan. Aims and objectives of this study. We try to manipulate anterior segmental osteotomy fragment with two methods of fixation: intermaxillary arch bar and mini plates, used to compare the efficacy of each one on the integrity of the osteomized segment, the outcome of each method to estimate the least side effect procedure, and the relapse rate and correction outcome which may correlate to the fixation procedure. Inclusive and exclusive criteria. Inclusive criteria involve patients indicated for upper and lower segmental osteotomy, patients agreed to be followed for more than 6 months, patients attend the orthognathic MDT committee, and patients age ranged between 16 to 28 years old with no gender predilection. On the other side, exclusive criteria involved surgeries are other than anterior segmental osteotomies, single jaw anterior segmental osteotomies are not involved, medically compromised patients, smokers, patients with periodontal disease are not included in the study, patients with poor follow-up are excluded also. We will pass to methodology. 150 patients attend the Orthognathic Multidisciplinary Team Committee per year with various complaints and different committees' opinions. The study involved a total of 43 patients where 86 jaws undergoing an orthognathic surgery, including upper and lower anterior segmental osteotomy from the period of 2006 to 2013 in a maxillofacial unit department, Al-Salam Teaching Hospital in Mosul, Nineveh, Iraq. The age of patients ranged from 16 to 28 years, 33 females and 10 male patients. Patients pass through the same preparation before surgery, including demographical case sheet, examination, investigation, orthognathic surgery MDT committee decision, and agreement, ethical approval for publishing, and surgery approval from patients and their families. All patients were subjected to anterior segmental osteotomy under general anesthesia. Patients divided into two groups. Group A, 43 jaws, the osteomized segment fixed with arch bar, while Group B, 43 jaws, fixed with mini plates. These divisions are recorded according to an isolated anterior segmental osteotomy, whether for the upper or lower jaw, even when operated in one patient. So it considered as a jaw case, not a patient. No intermaxillary fixation used for all patients. The materials used are the titanium mini-plate Shamby system, Orthognathic surgical set, Eric arch bar, surgical stainless steel wires, 0.5 mm. The incision for upper osteotomy involves a circular cheek incision at surgery, while for the lower arch osteotomy, a three-sided or shaped mucoperiosteal flap is reflected. Osteotomy is done according to the scientific basis, following the guidelines. Arch bar fixation kept for 45 days without any intermaxillary fixation, while plating was summarized by applying 2 plates for the segment with 4 screws for each plate. Post-operatively, patients followed for more than 6 months regularly. The integrity of stabilization and the quality for correction are clinically evaluated for both groups. Post-operative treatment was prophylactic antibiotics, analgesic, and dexamethasone ampoules used for edema. Post-operative instructions were given. All patients were asked to brush teeth twice, use mouthwash at least 4 times a day, and regular follow-up. Specially prepared patient information case sheets, particular identification code, and questionnaires for pain, swelling, bleeding, wound healing, and gingival health scale is geared up for each patient. Clinical evaluations of patient involve the following criteria: pain scale, swelling scale, bleeding scale, wound healing evaluation scale, oral hygiene index, integrity of stabilization, relapse rate, hospital day, duration of operation. Patients followed for more than 6 months regularly as follow: weekly visit in the first month, 2 regular separated visits in the second month, and monthly for the following 4 months. Statistical analysis was performed for the comparison between the 2 samples by using of SPSS version 20. We use frequency, percentage, mean ranks, and Mann-Whitney test recorded. Results of the study: 86 jaws sample, 43 each jaw. Arch bar fixation is considered as the controlled group, which is the commonly used one in different schools. The clinical comparison between the 2 samples involves, as we say, pain, swelling, bleeding, wound healing, and finally the oral gingival health. First clinical parameter for evaluation is the pain scale comparison. The pain perception scale is used on day 1 and day 7 post-operatively. Although the Mann-Whitney test show no significant difference in comparison, but Group A show less pain perception than Group B respectively. Table 2 describes the swelling scale, which is the second parameter. Most of cases show mild to moderate swelling. 8 jaws show severe swelling in Group B, while 3 jaws show severe swelling in Group A. On the third post-operative day, extend to be fully subsided on the 7th post-operative day. Bleeding scale comparison. The bleeding scale show highly significant difference between the 2 samples. Minor bleeding or simple ooze is recorded from Group B, for the first day post-surgery observation. Significant bleeding was recorded in one case. Wound healing scale. Complete soft tissue healing is evaluated in both groups on day 7 at the suture removal step, except 11 cases show stitch abscess, 9 in group A and 2 in group B. Table and figure 4 are describing the comparison. No significant difference are evaluated in B value. In gingival health scale, also highly significant difference are estimated in Mann-Whitney test. Concerning the gingival health scale, 11 jaws are show mild gingivitis in group A, which is arch bar fixation site. The other clinical parameters for assessment used are the integrity of stabilization. Checking of segment integrity immediately in operation before the closure of the flap reveal good stable surgical correction, whether fixation is carried out with arch bar or mini plate. But within the next 14 days post-operatively, manual examination of group A, 13 segments show mild clinical mobility. But one case developed clear, sensible mobility that necessitates the use of additional local type of fixation. So we use bar of cold cure acrylic resin applied directly to the involved segment and adapted well manually to cover the whole surface of the crowns of the surgical site, extended to cover the posterior non-surgical site crown, waiting for the applied bar and continuing the fixation period. Also, when patients from group B develop the same, this complication is treated with additional fixation as in case of group A. Relapse rate. In terms of late relapse as a condition that complicates the surgical correction, none of treated cases get relapse or fatal complication, including dangerous separation of the segment from its blood supply or necrosis. We don't notice clinically any case in both groups, but with a close, even short period, 2 jaws in group B who complained from an anterior open bite, which shows about 1.5 to 2 mm relapse. Also, the symptomatic cold plate removal and dental structure damage are one of the parameters which used to evaluation. We recognize 3 cases complain from sensitivity in their teeth in the osteomized segment. 2 of them were for group B, while the third case was from group A. 1 mini plate was removed 7 months post-operatively due to continuous sensitivity in terms of mild pain and discomfort in the site of operation, which subsided following mini plate removal. The other 2 cases managed conservatively with medication and follow-up, symptoms relieved a few weeks later. Hospital stay. All patients have admitted on the morning of the operation, except 5 patients who lived in the rural areas where admission done in the day before the process for accurate theater preparation. The patients are dismissed out of the hospital on the operative day. Those with complicated work in both groups leave the hospital in the morning of the next day. 2 patients leave the ward 2 days following the operation, one from group A and one from group B. Duration of operation. These results could be operator dependent, but as a mean time over all cases in group A was 90 minutes, while group B was 77 minutes. Now we will discuss the result of our article. The new concept ensures the use of many plates and is considered as a common fixation tool. Many plates are currently used for fixation of different fractures type and anatomical sites. In developing countries, many obstacles face us, especially in Iraq. Not all surgical facilities are available to be used, so we should try to approach patients according to general types of equipments. Arch bar and plating have a different controversy with pros and cons for each type. From this cohort clinical study, we try to highlight 3 important points: the efficacy of each one on the integrity of the osteomized segment. Also, we highlight the outcome of each method, estimating the least side effect procedure, including relapse rate, and finally correction outcome correlate to the fixation procedure. Ahmed Dannaf, which is a maxillofacial surgeon, stated that Eric arch bar was the most commonly used method for intermaxillary fixation in trauma cases before discovering the plating system. Pain and swelling are shared in both groups, with no significant difference except from massive surgery in both types. Moreover, a significant difference in bleeding scale related to plating with soft tissue manipulation is more advanced. At the same time, arch bar placement, on the contrary, can result in poor oral hygiene and gingivitis, reflecting high significant difference with stitch infection may indicate a negative outcome of using the arch bar due to the suture stitches underlying or in proximity to the arch bar. Using arch bar provide an accepted clinical stability at the operative time, and it's highly beneficial. Still, we may expect a possible degree of mild mobility later on, which is due to unwanted strain in the securing wires. One jaw from group A require an additional type of fixation in the next post-operative days. We complete to terminate the surgical work due to unexpected technical errors regarding aesthetic and aesthetic work. So, we try to secure the arch bar within a short time, leading to unpleasant mobility in the segment. We try to avoid future unwanted complication due to additional wires straining with time. This complication solved by adding a bar, as we say, of cold cure acrylic resin. In group B, deficiency in screws obligate us to use just one long plate, which is double Y mini plate, instead of 2 mini plates, enforced by direct application of cold cure acrylic resin 1 day post-operatively. Using arch bar provide accepted clinical stability at the operative time, and it's highly beneficial. Still, we may expect a possible degree of mild mobility later on, which is due to unwanted strain in the securing wires. The plating system needs a suitable adaptation procedure to perform accurate fixation, avoiding osteomized segment movement. Only two jaws from group B face an improper closure of the dentoalveolar anterior open bite 1.5 mm. These unwanted results were due to inaccurate plate adaptation. An arch bar in the fixation may resolve this problem by its mechanical ability to rotate the osteomized segment inward. Besides, one of the plate's side effects is proximity to the root apices, which may cause tooth sensitivity. Aesthetically, patients in Group B restore their cohabitation with the new better looking as edema subsided and suture removed. At the same time, those with arch bar fixation still have residual of the operation for the next 1.5 months post-operatively. In two patients who depend on the use of arch bar following a failed trial to adapt the plate over the stepped osteotomy margin. In the same patient, a plating was uncomplicated in the lower jaw osteotomy. Minor correction of some operative errors could be done post-operatively quickly with the arch bar by bending the arch bar in the new wanted position, while this correction not allowed in plating correction. Patients with preoperative fixed orthodontic work may interrupt the orthodontic brackets by using the arch bar. Fixation with the plate system minimizes the post-operative complication and ensure safe healing period. The arch bar could be maintained and valuable for special jaws with anterior open bite and setback wasement operations to prevent the unwanted errors in plate adaptation. The lower mucoperiosteal U-shaped flap is better restricted to jaws with the arch bar to avoid wound dehiscence. Most complications associated with the presence of an arch bar will be terminated at the time of removal, where still plating needs a challenge to achieve an accurate adaptation over the configured bone edges. Two systematic reviews discuss the Eric arch bar as the best fixation method from articles searching and reviewing. In 2015, Solo Garbel emphasized that arch bar are the gold standard method which give high stability for fixation. Besides, it can provide better stability in case of a prolonged fixation needed. Despite these characters, still some disadvantages as long operating time, needle stick injuries, high plaque index, and periodontal damage. In a study published by Al-Rawee in 2017, he accentuated that the most common failure of anterior segmental surgeries is the instability of the segment, which might end with relapse of the piece, highlighting the importance of fixation. Lingraj finalized that plating screws offer good intraoperative fixation, with less time of manipulation and also no penetration injury risk to the surgeon and his staff. He observed better oral hygiene, better patient compliance, and no major complication with the use of mini-plate screws. In the present study, good oral hygiene, less operation time, and are observed essentially in plating. Still, a complex adaptation that affects the stability of osteomized segment makes an arch bar preferable to be used. Conclusion from our study. From this study, We conclude that from the clinical assessment with the limited facilities and due to adaptation errors, we prefer to use an arch bar rather than mini plate to fix anterior segmental osteotomies. We are thankful to Dr. Keith Boswell, a maxillofacial surgeon from Newcastle, Dr. Riyad Al-Kamali, a maxillofacial surgeon from Iraq, Dr. Saud Salem Saeed, a skilled anesthetist from Iraq too, for their experts in diagnostic and clinical consultations. Finally, I will gratefully thank the committee for their invitations and thanks the participants for their listening. All the best. If there is any questions, we can answer now.